Thanks so much. I'm very, very excited about this presentation. So today we have Dr. Emilee Coulter-Thompson, who is a public health social worker with more than 2 decades of leadership and experience, specifically around health equity. So with Michigan Medicine since 2016, she's served as CVSSM's managing director and co-leads Michigan Medicine's LGBTQ Health Advisory Committee. She got her bachelor's at Miami University, her master's in social work at the University of Michigan, and her doctorate of public health leadership at the University of North Carolina. And so we're excited to have her present today.
Thank you so much, Sarah. It's such a pleasure to be here with all of you. Thank you for joining. And this is in honor of Michigan Medicine's Healthcare Equity Month. So I'm especially excited and honored to be presenting at this bioethics grand rounds and to be presenting as CVSSM's managing director. It's a lot of worlds coming together for me and being here presenting today my dissertation research from UNC Chapel Hill. And this topic is near and dear to my heart. So lesbian, gay, bisexual, trans, queer, plus parents experiences accessing healthcare for children with developmental disabilities. This is a topic that I have personal lived experience in and also professional experience. And it's really a privilege to have spoken with the families that I surveyed and interviewed. I'll tell you more about that later. But to start, I wanted to highlight some of the layers involved with this topic. This involves many layers of intersecting oppressions, starting with LGBTQ plus identities. And as an example, I've shown some families here who've experienced discrimination in multiple forms. It's difficult to find photos of families of children with developmental disabilities who are queer or trans. So I'm giving you some other examples. So in the upper left corner, you'll see the Welch Rogers family. They sued the Trump administration for experiences of discrimination related to their adoption process. Then the family next to that, Tristan Reese in the upper right corner, he and his husband Biff went public with their story when Tristan gave birth as a trans man. You can listen to, it's a very powerful and moving story on the Longest Shortest Time podcast. Tristan actually received death threats during his pregnancy journey, and they have a beautiful family story. I encourage you to check it out. Also, the Danielle family below there in the lower right corner, they experienced discrimination in their faith community. And in the lower left corner, the Love Ramirez family, they're actually from Ann Arbor. They spoke out about marriage discrimination before marriage equality was in effect. So I share this as some examples of the variety of oppression and discrimination that families are facing, even apart from healthcare and developmental disability care. But healthcare is really no exception. There are still bias and barriers in our healthcare system as well. And you can see another layer to these intersecting oppressions is disability. And both disability and sexual orientation and gender identity are identities that have been pathologized and over-medicalized over time. So healthcare has a particularly salient role in addressing these issues here today. Before I dive in, I want to acknowledge the land and make note to honor Indigenous families who have survived being displaced from their land, and also just multiple experiences of oppression and discrimination, especially LGBTQ plus and two-spirit parents and families with children with disabilities. And thinking about Indigenous relocation with respect to boarding schools and family separation, just bringing all of that to mind as we speak today about this topic. And I want to acknowledge my own positionality. So I identify as a white, queer, cisgender woman. I use she, her pronouns, and you can see some of my titles here. I've also been teaching as an adjunct in the School of Public Health on LGBTQ health. That was really fun this term. And nationally, I serve on the GLAMA Policy and Governmental Affairs Committee, which is GLAMA is the Gay and Lesbian Health. It used to be the Gay and Lesbian Medical Association. It's now LGBTQ health professionals advancing LGBTQ equality. And all health professionals are welcome at GLAMA. And you can see I'm a UNC graduate, and this is my dissertation research, as I said. And I also want to make note that my family experience definitely informs my passion for this topic. My wife, Roxanne, my son, Emmett, and daughter, Amaya, we lived in Oregon for 13 years. My wife and I met here in Ann Arbor, then we moved to Oregon for her to get her master's degree. And we stayed there for 13 years because at the time, marriage was not yet legal. And it was a really good place for us to give birth to our children because we could put Roxanne on the birth certificate. And we actually had an attorney come to the birth center the day each child was born so that we could make sure all the documentation was in place. And we didn't move back to Michigan until 2016 because marriage was legal federally in 2015. And I share that as another example of just the layers of barriers or kind of things affecting queer and trans families' experiences. Almost not exactly the same, but this feeling of being undocumented or having to carry your papers with you everywhere is something that we have personal experience with, and needing to be prepared if we ever had to show proof of parenthood or legitimacy in that way, and in healthcare as one environment. Now, how did I come to this topic? Looking at healthcare bias and discrimination in healthcare for developmental disability and children in LGBTQ families. While in Oregon, I worked with the Oregon Health Authority that was leading the way with healthcare transformation and working to align Medicaid with early childhood systems. So this is a complicated graphic, but it shows the overlay of the regions in Oregon for Medicaid coordinated care organizations and early learning hubs. And part of my role as a policy analyst was helping to advance that system transformation. And one of the milestones in that process was Medicaid providers had an incentive metric to measure progress on developmental screening, knowing that not all primary care providers were screening for developmental disabilities such as autism, ADHD at the same rate. And we wanted to increase it to make sure that children were getting adequate care and early intervention. And in the process of learning about all of that, I became passionate about this policy and systems change. I really thought my DRPH dissertation would be focused on that exclusively. But I had also, then I moved to Michigan Medicine. I was getting involved with LGBTQ health, and I stayed in touch with my longtime mentor in Portland, Jay Douglas. She's an environmental health director, also an out queer woman. And she said to me, maybe there's a way your research could infuse your passion for LGBTQ health as well. And I was asking myself the question, what is something that I can uniquely contribute to? So that's how I came to this topic, looking at LGBTQ parents' experiences and developmental disability in particular, knowing that there are disparities in developmental screening by parents and families' race, ethnicity, but nothing had been done around sexual orientation and gender identity. So I was curious to see if that was a similar barrier to parents accessing timely care for their children. Now I'd like to share a story, and this is a fictional story about a same-sex couple accessing care for their children for a child. And I crafted this based on examples from the literature and also my lived experience. Imagine a same-sex couple, Alice and Jess, taking their 3-year-old son, Jack, to a new pediatrician. The office form says mother, father, so they cross it out and write parent, parent. Then in the clinic, the doctor asks, who's the real mom? Offended, the parents say, we both are. Then the doctor says, oh, I mean, who gave birth to Jack? Alice says, I did. And then the doctor only makes eye contact with her for the rest of the visit. Next, the doctor says, Tell me about Jack's father. Offended again, the parents say Jack has a donor. And they quickly point out to the doctor that they haven't yet discussed the donor story with Jack. After all, he's only 3 years old. So they try to distract him with his tablet. After feeling uncomfortable throughout the visit, Alice and Jess don't share their concerns they have about Jack's development, and they leave feeling like they need to find a new pediatrician. So these are just some of the barriers that LGBTQ parents face when accessing care for their children. Now let's look to the data. So one estimate says that 2 to 3 million US children have LGBTQ parents. And this is very likely an underestimate because we know accurate sexual orientation and gender identity data is lacking across many data systems. Also, 1 in 6 US children has a developmental disability, such as autism or ADHD. And this means that approximately 500,000 children in the US with LGBTQ parents have a child with developmental disabilities. Also, queer and trans parents are more likely to have children through foster care and adoption. And it's been documented that children in foster care and adoption may be more likely to have complex health needs or developmental disabilities. So it's possible that queer and trans families are disproportionately more likely than cis heterosexual parents to have children with developmental disabilities. Now, among children with developmental disabilities, fewer than half of those disabilities are identified by the time children enter kindergarten. So this goes back to the early learning connection for the importance of childcare centers and preschools to be able to screen and know what's going on by the time children enter kindergarten. And this is important because children's brains develop rapidly, and we ideally would like to intervene as early as possible with developmental disabilities to give children the best long-term trajectory, ultimately to improve health outcomes and save healthcare costs. That is the ideal treatment window, so to find out before kindergarten. And so as an example of promoting early intervention, here's a poster that you might see in a clinic or preschool. And right away, you can tell that queer and trans families may not see themselves represented here in this image. It's not unusual for family-centered photos, promotional literature, health literature to show a kind of traditional nuclear family, a mom, a dad, 2.5 children, and a dog. So really what we need to do is diversify our imagery and this cis heteronormative bias and affirm LGBTQ plus families, make sure there's a welcoming environment, because discussing developmental disabilities, it's not an easy thing for parents to do, to talk about their kids' developmental concern. It's very vulnerable. And being able to establish trust and a welcoming environment really can impact the outcome on a developmental screening or intervention. When I started this research, I conducted a systematic literature review, and I cast the net wide. I was looking at parents' experiences accessing both healthcare and early learning, early childhood services. And I can say when I first started looking at the literature, it was a little disturbing because I was coming across the studies that were showing proof that LGBTQ parents didn't mess up their children, so to speak. Like, that's what the early literature was. It was very just kind of a baseline level of bias, trying to show, even just prove normalcy. So if you think about that history layered upon disability stigma, already entering this territory was a little bit, I don't know, a little bit scary for me. I was not sure what I was going to find. And fortunately, I did find 29 articles. They're across 8 countries, and there were 26 studies, both in health and early learning. The themes that they show are that LGBTQ parents frequently experience barriers disclosing about their identities. So telling the healthcare provider or preschool teacher that how they identified what that experience was like in relation to their children, and sometimes maybe discovering they weren't welcome at a particular setting. Also, one theme was around the forms and materials. So a lot of times our forms are still not up to date, as Alice and Jess experienced, having to cross out the mother, father to say parent, parent, or to have no place to describe a diverse family structure. So in that third theme here, showing non-biological parents or non-gestational parents or family structures that are outside of that traditional nuclear example, maybe where a known donor is part of the family, or there are step parents, there's any variety of diversity. Knowing that queer and trans families are formed through foster care, adoption, through genetic carriers, through not only through biological conception by one of the parents. There's a whole variety of ways. So that diversity is important to be able to communicate in a healthcare or early childhood setting. And the literature was sparse. The US studies on health specifically, there was only one study, and it was published in 1996. And there was one Canadian study looking at LGBTQ parents' experiences accessing care for children with disabilities. So that's how I decided to focus on healthcare in particular and to aim to fill these gaps in the literature. Around this time, the New York Times covered a story similar to this theme where the writer talks about her experience. She says, every time I start off my relationship with the institutions caring for my children feeling resentment. And she says that because the forms that she fills out in the medical environment don't fit her family, which really validates the themes that I saw in the literature as well. It seems like something that would be simple, something we would have covered by now, but you would be surprised just how often this shows up. And for children with developmental disabilities, or for parents with children with developmental disabilities, going through any sort of developmental assessment process means consulting with multiple specialists and filling out paperwork after paperwork, like form after form, repeating the same story. So if you're getting the same type of questions that are not fitting your family, it can really wear you down and feel like repeated microaggressions. My research question is, how does healthcare bias and discrimination affect LGBTQ parents and their children with disabilities in the US? And when I presented this to my dissertation committee, one of the audience members said, oh, you're assuming that LGBTQ people are automatically going to experience bias and discrimination. And it's true that, yes, I was making that assumption because for adults seeking care, it has been documented that adults experience bias and discrimination in healthcare and frequently avoid or delay care because of that. My conceptual model shown here is developed from the socio-ecological model and the World Health Organization's framework for action on social determinants of health. Basically, what this shows is that bias at a larger societal level, so the red boxes, the structural determinants such as the legal landscape or societal isms and phobias, filter down to create discrimination at the institutional level, the orange level there, where that means there may be insufficient training for healthcare providers, the forms and materials are not up to date to be inclusive, filtering down to the relational level where that can affect the relationship between patients and providers, creating reduced trust, and perhaps both parties maybe not sharing as much or misinterpreting each other's behavior, and in worst case, a parent perhaps being blamed or accused of it being their bad parenting that created what was going on with their kid and not actually a healthcare need. And then the individual child health outcomes could result in delayed screening and diagnosis and more negative health outcomes for these children. The study had 4 aims, the first being to identify the types of healthcare discrimination experienced and the impact on the timing of children's screening and diagnosis. I also wanted to explore parents' recommendations for how to improve care and develop a plan for change with strategies to reduce discrimination. The plan for change was part of UNC's model for a DRPH dissertation. And to address these aims, I conducted a national online survey and interviews with a subset of survey participants. And I'll speak briefly about the plan for change as well. So now on to the methods. My survey was an online Qualtrics survey with 45 items, mostly multiple choice. And parents had to self-identify as LGBTQ and to have at least one child with developmental concerns or disabilities. I didn't ask the specific disability, or you didn't have to have a confirmed diagnosis to participate. This was fielded during COVID, and unfortunately, the survey was interrupted briefly by bots and trolls, but I got through that and managed to gather 37 completed valid surveys. Also, the sample ranged across the United States. Most of the participants were from the states where I have lived previously, because this was a snowball sample. I started by sending it out to everyone I knew. I posted it on my personal social media and worked with all the organizations shown here. I'm very grateful for their help in distributing the survey. And let's see, so Oregon, North Carolina, Ohio, Michigan, and then a variety of other states were represented in the sample. The interviews, I asked everybody on the survey if they were willing to be interviewed. 29 people said yes, and of those, 16 responded and completed an interview when I sent out the invitations. I had a semi-structured interview guide. We spent about an hour together on Zoom. And again, these were interviews conducted during COVID, so I'm especially grateful that families were willing to take the time. It was right at the beginning of the school year. I knew there was probably a lot of stresses on these families at the time. And my heart just went out to all the families and in their courage to be able to trust me to share their stories. Now we'll go to the results and demographics. So of the sample, most participants identified as cisgender, lesbian, or queer women. I did have 4 men respond to the survey. 2 of those completed interviews, and 1 of those men identified as trans, the other as a gay man. Among the parents, most were highly educated. Again, as a snowball sample, I reached out to networks of people, and they were primarily in professional circles in healthcare and education already. 70% had a graduate degree, and 86% were white. Smaller percentages of people of color. And the family formation was about evenly split between people who had formed a family through giving birth or through foster care and adoption. Most families had 1 or 2 children, and a smaller percentage had 3 or more. So overall, the participants were highly educated. They were savvy about navigating health and education systems. I found out, at least during the interviews, many were healthcare professionals or educators, and there was a wide range of family constellations. That no 2 families were the same, different in terms of whether they were married, divorced, separated, single, and so forth. And the children were more diverse racially and by ethnicity than the parents. This was because some of the white parents had adopted children of color, and some of those families talked about their experiences of racism being more prominent than their experiences of homophobia or heterosexism. I didn't ask about specific developmental disabilities, but all families had at least 1 child who had some type of developmental concern. And it would be an area of future study to dive into more of that detail. The age of the children ranged. So some parents had had their experience with developmental screening and diagnosis very recently with children 10 or under. And then a variety of parents had older children and some even adult children. So they were thinking back many years to their experience at that point. Now, this is a little bit of a complicated visual here, but if you look at the dark blue, this is looking at the parents, the age of the children when parents were first concerned that their child had a developmental issue going on. So most families, their child was between the age of 0 to 5 when they first had a concern. And then fewer families, only three parents reported their child was between the age of 6 to 10. And then if you follow across, it shows that the majority of families, their child was first screened for a developmental disability when their child was age 0 to 5 and first diagnosed with a developmental disability between the age of 0 to 5. There was just a smaller minority of families for whom the child was 6 or older when that happened. And so this was pretty good news overall. And there was a small number of families that said their child had never been screened or diagnosed. Now, looking at the survey responses, AIM-1 was looking at the parents' experiences of bias and discrimination. And here's the good news. So some of the positive experiences that families had were that many parents reported feeling comfortable sharing about their experiences with their healthcare provider or trusting that their healthcare provider was giving them the best care, and they were willing to share sensitive information. So you can see they always or sometimes agreed with the statements here. A representative quote, one survey participant said, "Nothing about my family status has ever played a part in my child's care. They've always been welcoming." And now here are some families that reported that they experienced some perceived bias and discrimination. So when asking if the forms were inclusive, some said they were rarely or never inclusive. Many parents said that they had to educate their healthcare providers about their experience as a queer or trans parent. And about a third of parents said they had had fears at one point about disclosing their sexual orientation or gender identity to their child's healthcare provider. And now these are what I would say are never events. These are parents who said they felt their child had been treated differently because of their identity as LGBTQ, or that their child had been mistreated, or even that healthcare providers had blamed them for their child's health status. So the numbers here in red are small, but ideally they would all be 0. They would always be never. And one final one, a few parents did say they believe they'd been refused needed care for their child with developmental concerns based on the parent's sexual orientation or gender identity. Now, looking to AIM-2, asking about the timing of screening and diagnosis, fortunately, most parents said that they thought their identity had not at all contributed to delays in their child's care with getting screened or diagnosed. And this is not surprising given the sample, as I said, for parents who had a lot of choice in who their healthcare providers were, having insurance and savvy about accessing care. However, there was a small number that said it somewhat or completely contributed to delays. And for those parents, one participant said it was clear that we were the problem, not our son. And in this case, I interviewed this family. They had a male evaluator for their son, and who told them that they thought their son was uncomfortable with him because he had 2 moms, therefore must be anxious around men in general. So he was dismissing the idea that the son may actually have had a developmental disability and attributing it falsely to some sort of anxiety based on gender. Now, the interview results, looking at bias and discrimination. The themes are similar here, and parents reporting more about non-inclusive forms, challenges discussing their family's identity, and the non-biological parents or family constellations being dismissed somehow. One parent said, lots of times there's just male or female or mother and father, but a lot of times there isn't another option. And that's really hard because we don't see ourselves reflected in the paperwork. I'm an afterthought. I'm not good enough to make the template. And this gay male parent said when the provider had assumed that he was straight. And when he confronted the provider about it, he said, he just turned red. You could see the discomfort. That's all I had to say to him. I'm here for my child. I don't have the time to deal with your stuff. At the same time, I was having feelings about what just occurred. And the provider never did say, oh my goodness, I'm really sorry. I should not have made that assumption. So again, here's an example where the trust is impacted in this case. And a non-gestational parent was dismissed in the case of this family. The mom said, one of my kids was so upset by the provider asking the question, who are your real parents, that she actually wasn't able to work effectively with that provider who had asked. And it's not just the harm they're doing to my relationship with them as providers, as their parents. It's also the harm they're doing to their own therapeutic relationship with my kid. And I don't think they get that at all. So I think this is really powerful in acknowledging that kids are very aware of what's going on in the room. And in this case, the parent said that this child wasn't able to work with the provider at all. And this was very narrow options for working with a specialist, that it took a lot of effort to be able to find another provider. Now, looking at the timing of screening and diagnosis, similarly, we had most parents say it didn't contribute to delays, but there were 5 parents who did think that it was a contributing factor. And one of them said it 100% yes, did contribute to delays. And again, that one family in particular talked about their provider blaming the anxiety on them being lesbian parents. So what did parents recommend that we do in healthcare? First of all, they said to avoid assumptions and honor family diversity. And the second quote here, I think, is particularly powerful. Believe what we tell you. When I tell you that these are my children and this is my partner, there is no other question. And underneath this quote, I think, is that feeling of being challenged, like the legitimacy of LGBTQ parents, that given societal stigma, there's that layer of questioning or feeling like I'm going to have to show you my adoption papers to prove that I'm the legitimate parent, or a gay male parent feeling like, even though I'm male, even though I'm gay, I know what's best for my child. I don't have to be a woman. I can be outside of the typical stereotypes and still be the best authority and knowledgeable person about what's going on with my kid. Also, there was a request for queer and trans specific services. This queer mom said it was hard to tell if it was because I was white, because we were queer, or because we were unchurched. The multiple layers of identity made it hard to feel like we found our people. This white mom had an African-American child and spouse, and when they tried to seek care in multiple places based on race, ethnicity, based on queer identity, they really had a hard time fitting in any of those spaces. Also, improving the forms and written materials. This feels like low-hanging fruit for systems to address, and to create ways to ask open-ended questions about who is helping to parent this child? Who did you bring with you today? Tell me about your family. Just building in more open-ended ways for families to describe their diversity in their own words. Also, to reduce the repetitive storytelling and acknowledging the microaggressions that can happen when you're asking people over and over with questions that are not inclusive. They also talked about healthcare providers working on their own biases, using gender neutral language, using your pronouns at introductions, taking everybody's concerns seriously, and even specialists needing to post a pride flag and show that they're a welcoming environment. I also asked the families that I interviewed about whether they'd be willing to participate in a learning house system, learning community. I didn't go into all of the nuance of the learning house system model, but for this audience here today, I wanted to give a shout out to the Department of Learning House Sciences and this learning house system model that shows a cyclical process of improvement where a learning community puts the patients and families who are most impacted by a health issue at the center of the process, and that learning community can work together with providers and researchers to help identify and implement solutions for change. So most families said yes, they were interested in participating with something like that. And the families who didn't say yes or said maybe mostly had other commitments or were overwhelmed with other obligations already, but were interested in the idea. Now, my study's limitations overall were that this was a small snowball sample. There was limited diversity, and I would love to be able to repeat this study with a larger group and to really look at more diversity by education, income, race, ethnicity, and a whole variety of identities within queer and trans communities that were either non-represented or underrepresented in this study. Also, the bots and trolls were a headache, and more could be done to examine the diversity around disability, and there was not a comparison group. Overall, my takeaways were that some LGBTQ parents do experience or perceive the experience bias and discrimination when accessing healthcare for their children with developmental disabilities. And a large theme that stood out for me was just how diverse queer and trans families are. No two families are alike. And really, given the subset of parents I spoke to in this study, I believe that the bias and discrimination experiences were an underestimate. Just to help illustrate the family diversity, this is a visual that I created based on a study that was an article just published by Schnabel and Karaglian. And in their article, they talk about the rainbow colors from the red to the purple here. So parents, sexual orientation, gender identity, race, ethnicity, the child's identity, the way the families are formed, the type of family constellation, even the age when a parent comes out can have an influence on the dynamics of the family and the family's demographics. Then I added to this at the bottom, the white, pink, and light blue, the diversity by disability. So the age in which a child is identified to have a developmental concern and the type of disability and the level of or ways that disability impacts a family. It could be in the intensity of care that needs to be obtained, whether from an in-home care provider to someone who maybe has outpatient therapy. There's a whole variety of experiences that can impact the experience of the family overall. And another takeaway for me was the themes that parents shared about the basics of providing inclusive care. So mirroring the language that they use, believing what families say, and using inclusive language. So here's a wonderful resource. Our U of M Spectrum Center has a web-based course that we can use to review terminology and learn more about LGBTQ IA to Spirit Plus identities. So I really encourage you to check this out. We can put some links in the chat. My plan for change had multiple levels to it, including improving forms and materials, improving data collection, training, workforce development, and building parent support through a learning community. In the future, I would love to see additional research that's gathering more diversity about families and comparing heterosexual cisgender families' experiences to queer and trans experiences with disability care. Also directly measuring healthcare providers' knowledge, attitudes, and behaviors, and looking at bias and discrimination in education systems. I want to say thank you, especially to the families who shared their time and experience with me and all the entities here, my dissertation committee, and in the minute or so I have left before Q&A, I just want to call out a couple things related to Michigan medicine in particular. So the need for data collection is a passion area of mine, and that we need to improve how we collect sexual orientation and gender identity in electronic health records, program data, surveys, and research. And for everyone here, since I know you're involved in Michigan medicine in some form, I just want to tell you that if you can fill out a questionnaire about your sexual orientation and gender identity in the patient portal, if you're a patient here, but you have to know where to find it. It's an optional questionnaire. If you look down, that red arrow is pointing, it's buried in your chart. And then it's on the same page as the POC and procedure plan and I think disability accommodations. This is a screenshot of my personal form. You can complete your gender identity and your sexual orientation. And right now, this is the only way that Michigan medicine knows who its LGBTQ patients are. So this is something that I know is complex. There are many reasons that the EPIC system makes this challenging, but I hope that this is something that we can address in the future because we need to know who our LGBTQ patients and families are to be able to make population-based change and reduce health disparities. So I also want to invite you to come to an LGBTQ Health Advisory Committee meeting. We meet quarterly on Zoom. Andrew Hickok and I co-lead the group and all are welcome. Our work has led to a healthcare equality index score of 100 and Michigan medicine's the first time in our history in 2022, and we're hoping to have similar success in the new announcement that's coming out very soon. We also have an LGBTQ health research network that's newly forming thanks to IHPI's efforts. Contact MSEPI to join. And the Healthcare Equity Consult Service, I want to give a shout out for all their work in helping to serve and improve care for LGBTQ plus patients and families. Please come to the Michigan Medicine Pride keynote and celebration. Dr. Sari Reisner is an international expert in trans research and care. It'll be a wonderful time on June 6th. There are other local Pride events that you can check out. And there are trainings and many resources I'll include at the end here. This is our own OHE. We have the Spectrum Center, the National LGBTQIA plus Health Education Center. We get credit in our Healthcare Equality Index if you enter this code. And I have links to how to create inclusive forms, data collection, and my publications. So thank you very much. I look forward to your questions and discussion.
Well, I'll just start by thanking you, Dr. Coulter-Thompson, for such a wonderful talk on a very, very important topic, highlighting some of the systemic and institutionalized discriminatory practices. My hope is that your work is going to lead to large changes, both in how we collect data and better lived experiences for all of the families that we take care of. So we do have some questions in the chat. The first is that I think other people kind of sharing just that we're all honored to get a chance to hear your speak and you speak in your lived experience as well as the research that you're doing. There was some interest in getting a link to the Spectrum Center course, so we can share that after the meeting. There was also a question about the survey and how the survey was conducted and the sample size and how you navigated some of the issues around troll or bot responses and sorted through those.
Sure, thanks. The online survey, I really worked with the Odom Center at UNC, so they are comparable to services that MISHAR would provide here to researchers. they had a specialist who was very familiar with the bot and troll issue. And he walked me through in detail all the settings and Qualtrics that you can set up. So collecting the IP address of the survey respondent and looking at different things. Like when you look at the data, if you have bots and trolls, you'll see lines and lines of responses like 1 second after another. And they look very similar with Google addresses that don't really make sense. So there were some red flags that I looked for. But overall, I think I had more than 800 responses. I fortunately was able to cut off the bot and troll issue before it got to be too much worse, because I mean it was multiplying by the second. And and the other unfortunate part of that is that there were very targeted oppressive comments in the open-ended parts of the survey. It felt very much directed as if the whoever was responsible for it was looking for a survey that was about a marginalized community to be able to insert biased feedback. So it was not easy to go through it. It was really frustrating and also just kind of terrifying as a doctoral student to think like I could have thousands of data rows to sort through, but in the end, once I applied all the criteria that they sent me, and I'm happy to share that if anybody is doing a similar survey, I have shared it with other researchers, then it became more obvious and clear which ones were legitimate and which ones were not. But I think this is a common problem that online survey researchers are finding a lot. And there are publications out there now about these challenges and how they affect health research on LGBTQ populations in particular, I believe. Other questions? I know we have people in pediatrics in the audience and people who have a lot of expertise, and I am not a clinician, so I have to give that caveat that I really respect and value your feedback. And Kate, I see your hand raised.
Yeah, thank you so much, Dr. Coulter-Thompson. This was great, and also like a content area that I don't think we cover enough at CBSSM. So I really appreciated that in particular. One question I had, and this is not a novel question, but I'd be really interested in your answer, is sort of at the end, you were talking about how important it is to capture data on patient sexual orientation and gender identity. And can you talk to us a little bit more about the balance between patient privacy and disclosure of this kind of identity characteristics? Because of course, that also potentially gives the opportunity for more discrimination if a provider has access to that information right away.
Yes, that is something that I think about a lot. Overarching though, my experience has been that LGBTQ people want to be heard, want to be seen and heard and recognized for who they are. So while I realize that some individuals may choose to opt out or may not be at a point in time in a coming out process where they want to be open, maybe particularly with adolescents and adults having access to adolescent healthcare records, that's a whole other topic. But I think for adults who have queer and trans identities, it's so central to the experience of healthcare overall. Like it's so intertwined with whether someone has cancer or a chronic condition, or you need to know who your patients are. So I think for most individuals, it's worth the risk. And we have found at Michigan Medicine, we added sexual orientation and gender identity questions to the patient experience survey. And most of the pushback we received was from people who clearly didn't identify within the community, but were angry that they didn't want to talk about their sexual orientation and gender identity. They said, why are you asking this question? This is not important, and gave kind of oppressive, biased feedback about that. It wasn't coming from LGBTQ people saying this is an invasion of my privacy. And the way that we created a workaround is now the patient experience survey asks a yes or no question. Are you willing to answer these questions? Then the people who say yes can report their sexual orientation and gender identity and be counted, which for patient experience feedback is really important. We want to know by sexual orientation and gender identity, are there disparities or access issues that could be identified? And then for those who don't want to answer, they don't have to. But I still advocate for this to be a required demographic that we include in our patient health record. The same way every time you go in for an appointment, you are asked to verify your race, ethnicity, your address, that it's a core demographic that we ought to be gathering, and then we can offer an opt-out process if needed. But by and large, I'd say the majority of people do want to report. I think there are separate issues around researchers right now who are studying LGBTQ health and being out like on social media or a web platform and then receiving threats or harassment based on kind of that public identity. But there's also searchable data through NIH about who receives funding on particular areas. It's like, it's a balance that we're talking about in the LGBTQ research network. We don't want to shut down the work. We want people to still be able to be known for their expertise and advance the field.
We have, I think, time for maybe one more question. I'll maybe pose, there's two in the Q&A, I'll pose them together. One was about addressing gaps in training, because you had given the vignette about a clinician who had turned red, and thoughts about the training pathways for clinicians that could make them better prepared to address LGBTQI patients and parents. And then also, did you find any difficulty in publishing your findings due to bias in rates of publishing?
Thank you. The training issue, I think, across all health professions, that's LGBTQ families need to be part of core training. And I found in teaching LGBTQ health and in public health this past term, students from all different schools and colleges were saying, wow, I can't believe this is the first time I'm learning about this. Like, we've talked a lot about other identities, but not about LGBTQ. And so I think it needs to be baked in at the institutional level in medical school, social work, public health, information, all the health sciences, and not only be optional